Yes, today the goal is to talk a little bit, before I talked a bit about the 3 Ds of aging with dementia, delirium, and depression, today I want to talk more about kind of healthy brain aging and thinking about prevention for dementia. So I have nothing to disclose. All views and opinions are truly mine, and they do not reflect the policies or opinions of the federal government or the University of Washington. Additionally, I do have a disclosure, and that is that the picture on the cover of the brain with the gears, I did steal that. That was from a website, what was it called? Colorbox.com. I just lifted it from the inner tubes. So what are the objectives for today? I'd like to really, in case anyone had this misconception, I want to make sure I can dispel the idea that one can actually do something specific to prevent dementia, okay? I think it's important that we think about that because there are feelings of guilt sometimes with patients for not having felt like they've done the right things. And as you'll learn, there is no one thing you can do to prevent dementia. I'll review some of the top modifiable risk factors. And then hopefully we'll do a little flip on perspective and think about actually encouraging healthy brain aging rather than sort of that more negative sort of prevent disease kind of framework. And then hopefully by the end, everyone will feel a little increase in your skills and your confidence for how to respond to questions regarding prevention and healthy brain aging. I'll try to hit some of those common myths, discuss approaches to address them, and hopefully with some time, the pros and cons of early detection. I probably should have said that one other disclosure is that I always try to pack in a little bit more than I should to every lecture. So I'm really glad, I think as far as I know, everyone has a PDF of the slides. I've purposely put extra information on the slides so that you all have access to that. So first question, can we prevent dementia? You think it'd be an easy one, yes or no? It is no. The answer is no. We have no cure. We have no good therapeutics. In fact, frankly, our medicines aren't therapeutic at all. They merely have some goal of sustaining acetylcholinesterase in the brain, basically brain function for just a little bit longer. And frankly, we really don't even understand why or how people get dementia. One thing that does sort of seem to be agreed upon is that it's a disease of aging, but I would stress it's not necessarily chronological aging. It's more about the biology of aging and what happens to cells and other bodily functions with age, and other organisms would be similar. So I have this very busy slide, but that I really think presents a very nice overview of kind of our idea of cognition and aging. Those green lines across the top are this idea of what sort of normal cognitive aging would be. You'll see those are not straight across the top. They do go down often a little bit. There are changes that are considered normal with aging. However, for many individuals, they do have changes that are beyond what are expected for aging, maybe perhaps even progressing into that mild cognitive impairment stage. That would be when there's some concern about someone's thinking, there's one or more areas of thinking that are objectively impacted. But however, folks are still living independently. We think of MCI conceptually as sort of what can be an in-between stage, a prodromal stage to dementia. And really the biggest change there is greater cognitive impairment with that impact on activities of daily living. Now, one person's tipping point is always different from another person's. Some people have a lot of reserve and can have a lot of cognitive impairment and yet still be getting by day to day. So there's never this just one-to-one easy relationship. And of course, we can stage dementia from mild stages, moderate, all the way up through severe stages. So thinking about this potential process, what are the top risk factors? I do think it's first maybe to say, well, what do I mean by risk factors? Remember, every single one of us in this audience and tuning in, we have at least some risk of developing dementia. Because literally, as I talked about, it's this chronological aging. If you're alive, there's a chance. And so I will argue, though, that some of us have higher and some have lower risks. A risk factor is anything that increases one's risk of developing a condition. So it's not one-to-one, though, just like that's a take-home message here. Having a risk factor does not necessarily mean you're going to get the condition. And so that's a double-edged sword, because reducing your risk factors also doesn't necessarily mean that you're going to be able to avoid the condition. It's kind of complicated there. So we can't change age. I wish I remember some comedian, I think it was George Burns or somebody, made the joke, you know, the alternative to aging is not so good. I'm going to mess that one up, but it was sort of a joke, like there really is no alternative to aging, or at least it's not desirable. Also, we can't really change our genetics. So thinking about the risk of age, over age 65, the risk of developing Alzheimer's or vascular dementia does double every 5 years. So it's only 1 in 14 over age 65, but it's 1 in 6 over age 80. That's sort of a general number there. In terms of genetic risk, if we're not talking about those familial genetic mutation versions of Alzheimer's disease, it really is sporadic risk. We know that the E4 allele, the apolipoprotein E4 allele, does connote some increased risk if you have that allele, depending whether you have 1 or 2 copies of it. The allele has a general frequency in the population of about 14%. So those who have an ApoE4 1 copy of the allele, they do seem to have almost 3 times the risk of developing Alzheimer's. Those with a double 4 allele have as much as approaching 15 times higher increased risk. So these are things we can't do anything about. There's lots of great researchers out there that are doing a lot of work to try to figure those aspects out and come up with therapeutics, come up with cures. For the current time, though, as if we're clinicians and we're working on policy and with different populations, what I really think we want to do is focus on those modifiable risk factors. So I'm going to transition to some of the heavy hitters in that realm next. I think one of the greatest ones, and this is for Alzheimer's disease as well, is really vascular disease. So what causes vascular disease? Well, the main causes are hypertension and atherosclerosis. So atherosclerosis is this form of arteriosclerosis, that thickening of artery walls, accumulation of white blood cells, there's creation of plaques. Longitudinal studies show that having high blood pressure in midlife is associated with higher incidence of both of these types of dementias in later life. And that's actually where a lot of the focus has been lately. And so at times it was thought, oh, well, your blood pressure is kind of edging high, no big deal. It's worth it to take a more active, proactive approach in midlife. Do keep in mind, though, that there are some studies that suggest that when one is older, that hypotension actually can be associated with increased risk of Alzheimer's disease. So there may be a point at which kind of over clamping down on that blood pressure is actually more of a problem than a promotion of health. So the argument there is that maybe that decreased blood pressure actually reduces the cerebral perfusion. So you're getting less blood, less glucose, less oxygen to a brain that really needs it. Oh, and I wanted to say, as I flip my notes over here, that there are a few different things that additionally can really get in the way and contribute to vascular disease. So things like vitamin B6 deficiency, high cholesterol, which includes also high triglycerides, your LDL, HDL ratios being off, hypothyroidism, iodine deficiency. There's lots of nutritional things that contribute as well. And then importantly, smoking is a big contributor to vascular disease. And it is a modifiable risk factor. I know that it seems like a lot of people have given up smoking, but there really are still a lot of people out there still smoking. Having traveled outside sort of the Pacific Northwest recently, I was shocked to be on the East Coast in these big cities, lots of educated people going to and from their fancy jobs who were lighting up. I was in Germany just last summer, and I was shocked in Munich how many young people were smoking. So as healthcare professionals, I think it's really important that we don't let people forget about the serious risks associated with smoking. So this study that I have up right here is basically a combination of prospective cohort studies. They found 37 in this meta-analysis that actually met the standards for high quality. And I'm not going to read through all the details. I think you can see, though, the shift to the right here in terms of if you're smoking, increased risk toward dementia. So smokers have the increased risk of dementia, but I want to really emphasize smoking cessation. Actually, in many of these studies, found that it decreased the risk for folks down to that of never smokers for dementia. So I can't say it's never too late to quit smoking, but the second you quit smoking, you're quickly moving your bar back toward that of never smokers. So that really should be encouraging for people who say things like, oh, well, it's too late now. I've been doing this since I was in my 20s. And of course, current smoking increases the risk, even in those folks that don't have any kind of genetic risk factors. There is a little interesting twist that happens with the oldest old, and maybe you don't want to tell your patients this, but it does seem like there's a survival bias piece that comes in, and if folks make it up into their late 90s and 100s and they're still smoking, they seem to be doing okay. Somehow they don't have that, they've passed the bar that they were running toward before. So another big modifiable risk factor is diabetes. This is so often thought of as such a chronic and progressive condition, and it really doesn't have to be. I would do anything I could to promote the folks not developing diabetes, especially, referring of course to type 2 diabetes, that anytime you see that someone is starting to edge up with blood glucose numbers or struggling with nutrition, and maybe depending on where you're coming from, if you're in social work, maybe it's food insecurity and working with people to get them connected to learn how to cook healthy meals on a budget. It really is possible, but if you weren't brought up in an environment, a family or whatever, where that was happening, as an adult, you may really not know how to go about it. Or even in nursing, kind of just giving people those pep talks and encouraging behavior modification early. So both diabetes type 1 and type 2 are associated with cognitive weaknesses, and I have a couple of the examples here, particularly learning and memory in type 2 diabetes. We do find that there's a faster rate of cognitive decline, even if it's not all the way to a dementia diagnosis in those with diabetes type 2. So that risk of higher incidence of any dementia is much higher for folks with diabetes. Now, the mechanisms aren't entirely clear, but this same Lancet Neurology article has a lovely figure that kind of illustrates some of the potential mechanisms. So we think about sort of a genetic predisposition to diabetes, never forgetting, of course, that there's also a lot of comorbidities that can come along with diabetes, as well as medications one needs to take for the primary condition as well as secondary conditions. And those all lead to these underlying mechanisms, whether it's atherosclerosis or even more microvascular disease changes, but also even things like glucose toxicity and insulin resistance. So this is kind of that accelerated aging in terms of the biology of an organism. And those together sort of lead to the increased risk for Alzheimer's type dementia as well as vascular type dementia. And so I guess I went into a little bit more detail here, but really thinking about how it's not actually even the diagnosis of diabetes that's the problem. It's this relationship between insulin and glucose and metabolism, and how this has either accelerated or potentially with good glucose control, good insulin function, actually delayed aging can be seen. Lots of animal models show that you can kind of go the other direction and be more healthy, better glucose control, and see delayed aging and increased longevity. So there's also mental health conditions that have associations with increased risk of dementia. Who thinks dementia? I've only got 3 people in the audience right in front of me that I can see, but I won't say anyone call out, but a show of hands. How many people think depression has been associated with increased risk of dementia? I got 3 out of 3. That's what I expected. I have savvy audience members. Yes, but interestingly, the studies seem to suggest that it's early onset depression. And by early onset, I don't mean like in childhood, because I only work with older adults. In my idea, anything before 65 is early. So before age 65, especially if recurrent, that can constitute a long-term risk factor for the development of dementia. However, things are always tricky, aren't they? Late onset depressive symptoms should also be paid attention to, but mostly because they seem to sometimes be symptoms of this prodromal phase of dementia. So it's not uncommon that I get a referral in my memory clinic for an older veteran who's, say, 70 years old, and they are depressed. And the question is, are the cognitive changes their son is complaining about due to depression, or is it dementia? And I can basically assess and say, yes, there's depression. Yes, there's cognitive impairment, but because I don't know kind of which came first, I really have to just do more of a wait and see approach. But it never means you shouldn't treat the depression, okay? Recent studies suggest that long-term treatment with antidepressants can actually decrease the risk. Now that's the idea. Those studies have been looking at people who've been taking the antidepressants for a while, but there's nothing to suggest that the same mechanisms wouldn't actually promote at any point. So how about post-traumatic stress disorder with my N of 3 here? Who says yes, it could be a risk factor for dementia? I got 3 hands again. You are all correct. I don't have any prizes, but they're doing great. So it's double the risk. And I know really the veteran research, so older veterans who have PTSD or don't have PTSD being followed over time, those with incident versus not having incident dementia. And the studies pretty regularly show at least double the risk in the veteran group studied. Other populations can get PTSD. There's just not as robust an area of research there. How about anxiety? My audience of 3. Yes or no? Oh, I've got heads shaking. They are too good. It's not been consistently associated with risk of dementia or cognitive decline. I quote here just the Rotterdam study, which is a really strong study, and it was published in the American Journal of Geriatric Psychiatry just a few years ago. And so in this thorough study, they could not find an association. That's good for me, since I trend more toward the slightly anxious side. So, okay, brain health promotion. This is called Cloudgate. It's a public sculpture in Chicago where I did all my training. And I love it because even though it's not a reversed image, it just tells me to sort of change up your perspective, kind of think about how you're looking at things and focus in on different areas. So instead of thinking about dementia prevention, let's think about brain health promotion. So in terms of things that can help with brain health promotion, I wish I could tell you that there is like this one thing you should totally do. It doesn't work that way. But what does seem to come out pretty consistently in lots of different types of studies is that physical activity is associated with some decreased risk of dementia. Now, I want to set the stage here, though. So these physical activity guidelines are a little bit older, but they recommended 75 vigorous or 150 moderate intensity minutes weekly. That's 7.5 METs weekly as sort of what you should do for good health. But I have a study here that shows that the sweet spot is actually not exactly there. You're going to have to do more. Because looking at the study that looked at a dose response and pooled 6 prospective studies found that here, let me just do this. The median age in this, so it was with older adults, and it was actually, I should emphasize, looking at mortality. It found that that sweet spot is really more about 20 METs. Now, I don't really want to do the math, but 7.5 jumping up to 20 METs per week as being the sweet spot to reduce mortality is a lot more exercise than I'm getting regularly. So we want people to get physical activity that's within their, what's safe for them and their ability, start low, go slow. But everybody really does need to up it quite a bit. So that was sort of focused on mortality, but what about cognition? Does physical activity prevent cognitive decline in dementia? Well, this was a nice meta-analysis that looked at 47 cohorts, and they actually pulled it from 2 previous systematic reviews, as well as an updated search to put into the meta-analysis. They did look at individuals that were either 40 or older, and they looked at folks that were pretty much in good health. And so not reading through all the different pieces here, basically the conclusions were that these longitudinal observational studies did show an association between higher levels of physical activity and reduced risk of cognitive decline in dementia. Flipping that, basically healthy brain aging. the folks that had the higher levels of exercise. So they argue that you could make a case for causal interpretation, but of course, future studies should be designed to really think about the length of follow-up, randomized control trials, and a bunch of co-founders. So here's sort of the, why am I blanking on what you call this type of plot? Basically plotting out the different studies and their effect sizes, whatever the fancy name of that is. So of course the gold standard would be a randomized control trial. Wah, wah. So there are definitely more studies in the pipeline. I was at a conference in February where I saw some very small studies that showed really promising results. They were randomized control trials, but at the point in their data collection, they were small n's. But this review of the available RCTs at the time, the randomized control trials at the time, unfortunately, did not find significant benefits of aerobic exercise or increased fitness on any aspect of cognition. Now, though, the caveats, a lot of the trials had methodology problems or they had difficulty with their reporting, which meant that aspects of the trials were left out of certain pieces of the meta-analysis. So for instance, a number of the studies in terms of a marker of cognition only had like a global status type thing, like an MMSE. Unfortunately, it doesn't change the fact that they did not find the association. They do argue, though, in this Cochrane review, that it would be important to remember that there may be some subgroups of people or maybe perhaps more intense exercise programs that could be beneficial. And in general, these were not particularly intense exercise regimens, what they were covering back a few years ago. The newest studies are definitely pushing people further. They're doing a better job of measuring actual like physiologic change in terms of oxygen, VO2, as well as intensity levels and getting people up higher. So other research has really focused on social interaction as something that can be useful for trying to promote healthy brain aging. This is based sort of on the flip side, which is that seeing that folks who become socially isolated are at increased risk for dementia and cognitive impairment. The study I put here is from the Rush Memory and Aging Project. It's a longitudinal epidemiological study. It has clinical pathological correlation. Most of the people in the study, if they pass away, do come to brain autopsy. This particular component only had 89 older adults in it because they had no dementia at baseline, they had their brain autopsy data, and they had also completed a bunch of questionnaires, basically, that really got at their social network size based on a whole bunch of different factors. So they included covariates, including cognitively stimulating activities, and they found that even when they controlled for those other things, the folks that even those with more severe levels of pathology in their brains had higher cognitive performance if they had been socially engaged, if they had essentially what's called like a larger network size. Now, I do want to say this, though. You don't have to be social like you're going to cocktail parties and having to make small talk with strangers. Your social network can be comprised of family and friends as long as you're actually engaging in social conversations and activities. So I had mentioned mood, but also sort of the flip side of having a mental illness or a mood disorder is sort of more emotional wellness. And so we kind of have seen that you can treat mental health issues and that can reduce associated dementia risk, but there's even a step further you can take. Not just treating dementia, but actually trying to decrease stress, increase laughter. And this particular study looked at extroversion and neurotic personality types, and basically found that low neuroticism and high extroversion were associated with reduced dementia. However, even if you have low neuroticism, if you're inactive and you're socially isolated, you're right back where you would have been, and you have increased risk for dementia. So these higher scores on well-being questionnaires and having high lifetime motivational ability were all associated with sort of a preserved cognitive function in older age. So the study, I should have said it actually, it's a decent size. It's 506 older adults from a larger cohort study. All right, I think what interests me a lot always is the nutrition, kind of aspect and thinking about, well, what am I eating? What kind of fuel am I putting in my body? I would argue that really the focus has been on what's sort of more considered a Mediterranean diet. So just there's lots of different interpretations of what this is, but typically it involves a high intake of vegetables, fruits, nuts, legumes, unrefined grains. You can have lots of olive oil, but low intake of some of those saturated fats. So the whole trend of coconut oil, and I love butter, but that doesn't really make the list of an unsaturated fat. Having a moderately high intake of fish, of course we're thinking about things like omega-3 fatty acids there, as well as just sort of lean protein, and a lower intake of dairy, meat, poultry products, and moderate intake of wine with meals is a one that could be an option. So the observational studies have suggested that in addition to reduced mortality, they see other aspects of reduced chronic disease, especially cardiovascular disease, which have all been associated with that more healthy aging and long longevity. So the kicker, though, is that the Cochrane review that looked over a bunch of these studies, they found 11 trials that met their criteria, which are good and strict, actually found limited evidence. What I would say, and here's one more thing, in studies that had a strict reduction in fat intake, both cohort and RCTs, there was limited evidence for reduction in cardiovascular events, breast cancer, and type 2 diabetes. They didn't look at the dementia specifically. One thing I would say, though, is, and I really had this hit me when I was listening to a talk, was when we create a randomized control trial for a Mediterranean diet, we've kind of erased the context in which folks that eat, most folks in these observational studies are eating this as like a community in a region of the world. So having gotten to travel abroad this last summer, I was reminded there's this huge social aspect that goes on. I'm in Italy and I'm seeing families that all get together for this big meal. And so they're eating the diet, they're drinking a little bit of wine, but they're also talking to each other. And there's just this additional piece that a randomized control trial is not going to have in it. So I still believe that there's a lot of hope here, but we have to not just think so narrowly that there's one specific thing to eat that's going to help, or one thing that we shouldn't eat that won't help. So I'm going to bring up alcohol, and this one's an interesting one. I think first and foremost, I don't want anyone to lose sight of the fact that alcohol use, especially alcohol use dependence and disorder, can actually be both a primary and secondary cause of dementia. So I love to joke about how much I'm so glad that glass of red wine is something that's good for me, but we really have to remember that it's in such moderation. So I first am kind of drive home some of the negatives of alcohol use before I kind of flip my perspective. Long-term excessive drinking literally causes damage to the brain directly on its own, okay? Neurologic damage, impaired cognitive function. We typically think of alcohol-related dementia or Wernicke-Korsakoff syndrome, but there are other more mild neurocognitive disorders that have shown to have direct association. So drinking more than recommended amounts also increases risk for vascular dementia, Alzheimer's disease dementia. It also increases the risk of stroke and heart disease. And it's really important to remember that of older adults, 2 to 10% abuse alcohol or are alcohol dependent. What they drink, what folks, even if it's the same that they were drinking when they were younger, it could now be too much based on changes in metabolism and other factors with aging. There's another piece to this puzzle when working with adults, older adults. Older adults are often at increased risk for falls, delirium, head injury. And so the chance of a little wobble being disastrous are much higher in a lot of our older adults. So there's many reasons usually to recommend cutting back rather than, oh, you should add a glass of red wine to your 3 beers a day habit. So I have here a graph that basically is one of those J-shaped curves. It's a meta-analysis. It's a bit older now, but it was looking at mortality risks based on drinks by day consumption. And so you can see the dotted line there is the mortality risks for women, goes way up as the drinks per day goes up. Similarly for men, although it's a little further out for the numbers of drinks before it goes up. I would note though, and I'm not sure I have a mouse that will work on this, but if you look at the far left side of the curve, there is this place where it almost looks like no drinking is like worse for you than, what is that, about 1 drink a day? And so that's where people got really interested in, well, maybe there is something to some alcohol consumption. So again, back to the negatives here though. Lower alcohol tolerance occurs in older adults because of decreased metabolism and blood flow, decreased lean body mass, and a decreased like basically water content in the body. Women, we don't get it lucky. Our metabolism slows down even more so than men as we get older. And I mentioned before about, what did I say? Was it 2 to 10% of older adults have a truly what meets criteria for a substance use disorder with alcohol, but at-risk drinking is found up into at least 15% of folks over 65. So think about it. There's actual meeting criteria for a substance use disorder, but there's also just sort of at-risk drinking where maybe an older adult is having 4 cocktails. And maybe that wouldn't be too much for an entire week, but that kind of binge really puts them at risk for many other conditions, as well as acute falls and problems there. Additionally, if I haven't already made you scared or worried about your older adults that are drinking regularly or possibly too much, think about the potential interactions with medications. We know that pharmacy prescriptions go up, often with age, with conditions, and many of our older adults are already in a condition of a situation of polypharmacy. So adding alcohol onto that is like fuel on a fire. So the NIAAA does have recommended drinking limits for older adults, no more than 1 standard drink per day or 7 per week. That's for men. Women get fewer. No more than 2 to 3 drinks on any drinking day. Again, for men, women, it's fewer. And the website that I have listed here goes into more detail. What I have to remember in my memory clinic, that's for folks without cognitive impairment, right? So add in a little mild cognitive impairment, add in somebody who's maybe on pain medication or sleep medications, things like that, and you really do have potential problems. So how do we respond to our patients? I gotta tell you, my patients are way more up on the latest news flash or fad than I am. Bless you. I'm constantly hearing about things that just, I'm like, what? So right before I came in today, I did a quick Google search, right? That's where you get all your good information, of just dementia and news. And I was excited to see that recently the FDA has cracked down on mislabeling of supplements. And basically suggest different companies that are putting out products that they suggest could actually help cognition when they can't. I saw, let's see, what else did I see? Oh, there's a holy herb extract that shows promise as a future treatment. It's yerba santa. It's a California herb that they have said the extract of it can protect against inflammation and other triggers of brain cell death. So I thought that was really interesting. I'm not putting it down, who knows, but it does feel like every few months there's some big new thing. Last year when I gave this talk, there was an article that said, flies hold the answer to the cause of dementia. It's a year later and the flies have not given up the cause yet. They are still holding out. What I do see even more than these sort of quick fix promises is I see really sad things like Cleveland police search for missing 86-year-old man with dementia. Lifetime of saving won't cover dementia cost. So I really want to emphasize that we have folks coming to us looking for that little like silver bullet, but remembering that at the base of it all often is a fear of all these different psychosocial aspects that can occur when one has dementia. And depending where we are working with someone and where they are, we really want to think about meeting them and helping them be proactive for the future with or without cognitive impairment at the point that it could cause dementia. So here's just a few of the things. These are ones that actually have stuck around a little bit more, right? Ginkgo biloba, omega-3 fatty acids, coconut oil, alcohol, I've already sort of covered that. Statins, diet manipulations, brain games, vitamin E, and I can get later on, but other things, we know now we should really avoid benzodiazepines. Those are associated with greater risk. I think some of the most interesting work coming out in the last couple of years is these sugar substitutes, and showing that people use them to keep from having increased glucose, basically like calories. However, we act as if like that's the only thing that happens when you ingest glucose, that there's sugar in your gut and it sends signals to the pancreas to produce insulin or that sort of stuff. We forget that this is all centrally mediated. So if our stomach thinks it got sugar, our brain gets signals that it got sugar. So our brain actually kicks things up as if we had sugar. And most of these sugar substitutes are like a whopping dose in terms of the flavor of sugar. So you're really kind of confusing your brain a lot with these. I know there's other mechanisms that have been implicated, but I kind of find myself really going back to that you're really confusing your brain about what it's getting and what it needs to adjust for. So I thought I'd just touch on Ginkgo biloba. I don't hear this as much, but every once in a while I hear a holdout, and I understand why people are excited about it. As of last year, realized I forgot to update this slide. I had only found 2 randomized control trials. There were the sort of that gold standard double-blind trials. And unfortunately, from those, there's no convincing evidence that Ginkgo biloba, at least in late life, can prevent the development of dementia. And unfortunately, when you find that kind of result, nobody's going to start up a randomized control trial with 20-year-olds. Nobody's going to get funding for that. And probably, given that they never really found a good sense of what the mechanism could be, it's not that it doesn't make sense. Omega-3 fatty acids, well, why would we think those would be helpful? A lot of the diets, like the Mediterranean diet, typically is somewhat higher in omega-3 fatty acids. And there's some research, animal-based and other, that suggests that those long-chain polyunsaturated fatty acids, the PUFAs, actually can protect from cognitive decline in animals. However, in humans, that direct evidence on incident dementia is lacking. There's a few trials that did not show the benefit on cognitive function specifically in cognitively healthy older people. But I would say at the end of the day, there's a basis for this. And the supplementation of it is generally well tolerated. And so if your folks are going to take one supplement or try to increase something in their diet, maybe even a better way to do it, that's probably not the worst thing to do. So then my take-home messages is, well, why take the pills? Why choose this when you can choose this? We know that our supplement industry is not well regulated, and our federal government is not exactly doing more to regulate things these days. So just take everything with a grain of salt and perhaps get your nutrients from the natural sources would be my plug. And no, the avocado industry is not paying me, or the salmon industry is not paying me to give this talk. All right, coconut oil. This one is an interesting one. It's, it's an edible oil. It's taken from coconuts. It has a really high saturated fat content. It's very slow to oxidize. And the claims have been that it can improve thinking in dementia, it can reverse dementia. I've even heard it can prevent dementia. However, most nutrition professionals, I've spoken with many people at Bastyr and other places, would say that coconut oil consumption should actually be limited or avoided. If you are someone who is low weight and needs, there's different conditions where it might be worthwhile to try to use coconut oil, but for most ordinary people, it's actually not good for you. It's more likely to have a negative effect on your cardiovascular system than it is positive. I really think this one got a lot of traction many years ago. This is like less than 10 years ago, but more than 5. I can't remember when exactly it came out. But there was a physician whose husband had dementia, and she posted like a YouTube video of sort of him in his more moderate to severe stages of dementia. And then she gave him the coconut oil, and then she posted more video of him looking much more vigorous and with it. And that kind of just sparked things, right? A doctor says this will help. And just keep in mind that when folks have cognitive impairment, when they've got a loved one with cognitive impairment, they're feeling often very desperate for anything that might help. So I mentioned the light to moderate alcohol. This is a different study that pulled together, meta-analysis that pulled together a number of different studies that looked at moderate drinking, so light or moderate alcohol intake, and the risk of dementia. And they actually, what I liked about this study was that they broke up their cohort by different risk factors and looked at gender effects. They looked at the cognitive level effect, and basically saw that it does seem like a little bit of alcohol might be associated with less cognitive impairment or decline is probably the way to put it. Let's see. So what would be the mechanisms by which light to moderate alcohol might actually be helpful? Here's a nice little graphic I stole from this article from 2012 that suggests that there are certain aspects that might actually increase acetylcholine production and availability in the hippocampus. It might protect via vascular risk factors by actually opening up blood vessels a little bit, sort of that vasodilation. And other ideas that there may be some antioxidant effects. That's kind of where the red wine piece comes in. So the red wine piece. So nowadays you can buy these like supplements. You can go into really any store, and it's the resveratrol, which is basically synthesized in lots of different plants. It's not just grapes, peanuts, blueberries, pine nuts, but it does seem like in grapes it's more concentrated. But even there, I have to emphasize the amount of grape skins one needs to produce the resveratrol that was shown in any of these animal studies to have a positive effect. You would have to drink a lot of red wine. In fact, it's probably beyond what anyone could consume. So that's not the way to get it, certainly, with red wine consumption. But unfortunately, even these supplements haven't been shown in any trials to actually, in humans at least, to do anything as well. So statins, oh gosh, I can't believe I kept this in here. I thought about getting rid of it. It always comes up. Are they good? Are they evil? Folks really come down hard on one side or the other. I think, so this is a 2016 Cochrane review that, and I'm just going to read a little bit from the conclusions, basically that for people at risk of vascular disease, if you give them statins, it does not necessarily prevent cognitive impairment. It's biologically feasible that it could, but they really couldn't find that there was a positive benefit to statins on cognition, on preventing dementia. Now, I back up and just say, but remember, if you have really high cholesterol and you're not doing something about it, you're at high risk for vascular dementia and other aspects of cardiovascular disease. So it would be great if we had ways of modifying cholesterol and other risk factors other than taking medications. And as sort of allied health professionals, which I think I typically have in this audience, I think, especially as I'm a non-prescriber, so of course I lean toward non-pharmaco solutions, but our jobs are really to help supplement and promote, physicians and folks that are doing the prescribing may be doing a statin, but I really think that we should recommend and promote these healthy behaviors, which could lessen the need for the statin, maybe erase the need for the statin. That sort of goal. So there's a lot of fads out there with these diet manipulations. Everyone here at this point has heard like of keto diets. Well, Atkins, I think is sort of what it was called in an original formulation. And the idea is that a lot of these are based on the premise that you are really actually restricting carbohydrate intake. Now, there are research studies that have shown that tight restriction of carbohydrates can have good benefits for folks with metabolic syndrome and type 2 diabetes. Okay, so there are potential benefits for certain populations, but for someone who doesn't have problems with their insulin or glucose regulation, you could argue that maybe some crazy manipulation of sort of a more natural intake could create problems down the line if you were ever to either go over the line of carbohydrate restriction or to swing back to a more sort of typical diet. We do have to watch out, and in fact, that was this comment here, the second bullet point. When carb intake gets very low, there's some evidence that the body might actually start to induce an insulin-resistant state, basically to keep spare blood sugar and glucose for the brain. So I just gave one example here of a study that actually showed benefits. They did compare 2 different studies, the low-carb ketogenic diet versus just a straight-up low-calorie diet. And you can see that both diets actually had a lot of beneficial effects. This was in folks who were overweight or obese and did sort of meet criteria for needing to find some way to restrict calories or change up their diet. So another diet manipulation that gets talked about sometimes is caloric restriction. Audience, anyone heard of this one? It sounds miserable. That's what I'll say. That's my editorial comment. It sounds miserable. The idea is that you're somehow providing all the essential nutrients and vitamins, but significantly lower calories. Some of these people are 70% lower calories than their recommended daily allowance. And there's arguments that this affects the insulin growth factor signaling and can be a positive. And if I can flip to my page here, that the rapamycin TOR pathway is affected in a positive way. So basically in a way that prevents sort of this biologic aging. However, I want to emphasize some of these diets have serious side effects. Folks can develop edema, cytopenia, proteinuria, oral ulcers, dyslipidemia. I mean, it seems pretty extreme to me, but there are studies that show in certain animal models that it can extend the maximal lifespan and delay morbidity. There's only observational data in humans. I don't know of any randomized control trials that have been done. I think we could argue that that would be very questionably ethical. Thank goodness. And thinking back to the whole like de-stress, be happy kind of, there's got to be a sweet spot, right? Like it seems pretty miserable to me to be depriving yourself just so consistently of what your body is calling out for. Brain games. I hear about these probably once a week at least. The take-home message here is that cognitive stimulation is good, right? Thinking new things, pushing yourself, not doing the same thing day after day, very good. But the benefit of systematic, specific cognitive training does seem to be domain specific. So if I use one of those super popular online kind of like brain games, and I practice it regularly and I work at it, I get better at it. And then when tested on it, I'm better than I was before I did all that work in practice. However, if you then go and test me on some other sort of real life memory situation or working memory situation, or even a different paper and pencil measure of working memory, that effect does not hold. It doesn't transfer very well. So it just doesn't really generalize and has not been found to affect everyday functioning. Also, those that already have memory impairment may be less able to make gains from training. However, then I say, if someone's having fun doing it, Sudoku or crossword puzzles, there's no harm. There's definitely no harm. The only thing that I would say is harmful is I had a spouse come in, brought her partner in, and she was like, I know he's going to be better this time, doc, because I've been making him do crossword puzzles. And this patient just looked at me, and the look on his face said, please save me. Because he hated crossword puzzles. He never liked them. And she was literally hounding him all morning to complete the crossword puzzle. So we were able to do a little fun work where we came up with a couple things he does like doing. He likes jigsaw puzzles. Now he's doing jigsaw puzzles, and their relationship is actually much better as well. Lots of research talking about antioxidant supplements. There were a couple big studies that came out just a couple years ago, and even some newer ones just in the last few months. The continuing take-home message here of the last couple years is taking supplements without evidence of some sort of a deficiency that you're correcting for. If you're already taking a healthy diet, they're just not recommended. If they are water-soluble vitamins like vitamin E or C, you basically are just flushing them out. If you're lucky, you're flushing them out, right? And you're spending money, your body's dealing with that when it really should be doing its own normal metabolic process. There are some supplements that are not water-soluble that are, sorry, am I saying this right? That basically get stored in fat, and you can end up with toxicity. So vitamin D, I watch out for when vets come in and they're like, oh, I've been taking these like mega supplements. And I'm like, ooh, you have not had your labs checked in a while. We are sending you off just to make sure that they haven't thrown things really out of whack. So a lot of studies actually that were looking at different types of supplements, vitamin E, selenium, things like that. Many of those studies have just been closed because they're not finding any positive evidence. So what else have you heard? I mentioned no sweeteners, no benzodiazepines. There's studies that have looked at, let's see if I can pronounce it correctly, curcumin. And there's some thoughts that maybe there's something there, but it's still being looked at. In terms of those the big name supplements, has anyone heard of Prevagen? Prevagen. Their website says people who use Prevagen experience improved memory. This is quotes, experience improved memory, a sharper mind, and clearer thinking. It's their own studies that they quote. It's horrible. You can't find them published anywhere. These are certainly not being published in peer-reviewed journals. The FDA has gone after them a number of times, as well as the FTC in terms of like making false claims. So yeah, their best company-sponsored trial that they quote has 211 people in it. They were all totally healthy people, middle-aged, no cognitive impairment, and it still wasn't even a well-done study. So very disappointing. So, but we're gonna have to keep dealing with this. Anytime we interact with people, I interact with my parents, right? So what am I supposed to be taking? Don't try to take anything. Just try to do things that are healthy for your brain and body. We often have to deal with questions from our patients or other people that we know. So my recommendations, my tips, is number one, be composed. Try to avoid a strong positive or a strong negative response. Trying to remain impartial and neutral. Remember that when people come to you saying they're taking something, they do think it's doing something. And to have a reaction of, oh, is not helpful for your therapeutic relationship, right? On the other hand, being like, wow, that sounds so cool. I don't know about that. You should, I'm going to look into it. Sounds great. Would also be just as equally bad. So it puts a lot on us. Keep up with the literature. I would say I try to keep up with the PubMed, published peer-reviewed studies literature, but I also try to pay attention to the popular press. If I'm on social media and I've got a newsfeed thing that flits up with something about dementia, I kind of tuck it away in my head, like, okay, I may hear about this, so that I can do a quick search, see if there's anything there. So I'm not totally surprised when I get the questions. I think it's important to remember you want to show people, not tell them when you're providing education. So me sitting there in my chair on the other side of a table saying, oh yeah, vitamin E is bad, or there's nothing good about it, I should say, it's not bad, is not nearly as helpful as me having an article that I can point to, graphs, pictures. A lot of times there's some really reputable news outlets that will publish sort of more easy to read, easy to digest lay articles. The trick is those are so much bad press out there as well in terms of the quality of the writing and the investigation. Remember that every news article wants to sell you something. Usually they want you to buy their paper, so they often have very fantastic headlines. Read those articles and help your patients read them critically to get to the nuts and bolts. Often by the time you get to the end of the article, the person, the lead author of the study is like urging caution. Let's not get too excited yet about these results. But that's not what hits the headline, right? Let's see, big claims, ask for big money. I tell my patients, if somebody promises you something that seems unbelievable, it's unbelievable. Brain games, if they want a lot of money, not worth it. There's nothing behind that. I think one of the worst things out there isn't so much on, is like things like having people pay out of pocket for fancy brain scans to show them their abnormal pattern of brain activity. And then if you take our supplements, you'll pay us $1,500 more and we'll give you a brain scan, and now we'll show you how your brain activity is regulated. This is all crap. Excuse my language. The flip side of it, though, is people need hope. So trying to provide this balanced viewpoint, encourage people to get to a balanced viewpoint on their own without squashing hope is pretty pretty tricky. Kind of an important piece, and it sounds like there's now a talk that's coming up that will be sort of talking about early detection of cognitive impairment. I probably don't need to cover this so much, but I do think we have to remember that there's pros and cons of early detection of cognitive challenges. There's a United Kingdom National Screening Committee that was kind of addressing like, well, should we be giving a quick cognitive screen to everybody over a certain age? And that made a lot of sense to question that and think about it in the United Kingdom because they have their socialized medicine. And so if there's a public policy and preventive reason to do it, it could be very useful. The first question, of course, is this an important condition? Is it a common condition? Thus, the screening would make sense on this widespread level. Yes. Is the natural history of the condition well understood? Well, no. In terms of dementia, it is a syndrome. It's not a specific disease. And in life, we really don't know what exactly is causing the clinical syndrome, right, of cognitive loss and loss of independence and daily function. So until we kind of have that better put together, that's a tricky one. Now, is there an effective treatment which, if given early, changes the natural history? Well, no, we have nothing like that yet. And then we have to think about, do we have a simple, cost-effective, reliable, and valid test? Well, no, we don't even really have that either. So basically they came down on the side of there's no reason that we should be doing cognitive screening in everybody, say, over a certain age. However, of course, I'm a neuropsychologist, and I do believe, though, there's a difference between screening all comers and evaluating those with red flags. And so that's kind of what my previous talk kind of hit on, was really how to be tuned to the red flags. I would also say that if you've never given one of those brief cognitive measures to someone who's totally cognitively normal, you may sort of have your barometer misaligned for what is impairment. So I'm not saying to go out and give cognitively normal people memory screens, but keep in mind when someone does well on it, that's more the norm rather than the exception. So I just think that we can kind of, the same way that certain prescribers write down like an RX sheet that has like, here, take 2 of these and call me in the morning as the prescription. I think we can put together sort of our RX for healthy brain aging and have certain things on a list and write them out for patients and tell them, here are some things you can go work on. Or you've told me that you've gotten really sedentary since your dog died. Think about ways and brainstorm together for how you could get more active again. Maybe someone could go volunteer with animals and take some for a walk if having a new animal in their life would be too much of a burden. Different types of brainstorming that can really boost some of these things for healthy brain aging. So, summary points, there's no such thing as dementia prevention. Saying that suggests that people who get it have done something wrong, and I want to be really careful that we don't have that happen. But promotion of healthy brain aging should be a top goal. We want to always think about modifiable risk factors, diabetes, vascular disease, excessive alcohol use, and smoking. I would also add in there trying to get folks to, if they have a sleep apnea, getting it diagnosed and treated. We want to keep up to date on how best to promote brain health. And we also really just want to help our clients, our patients, seek out reliable information and make these positive behavioral changes. So thank you very much. I thought this was a nice National Institutes of Aging NIH resource on brain health, this website here. And I have my email addresses are there as well if anyone has a question that they'd rather email me. But I'm hoping Barb has gotten some questions in the chat box. Yeah.
So the first one is just when you had posted about what are you hearing? Somebody was asking about vitamin B12.
Yes. So vitamin B12 is not necessarily something you would take. There's no research that shows that taking above what you need of vitamin B12, like higher doses, mega doses, would promote cognition, but there is really solid research showing that if you are deficient in B12, that can definitely cause some cognitive I would call it like lack of clarity, and some other kind of minor health changes. So that's actually on our panel. If someone comes in for a dementia evaluation, we always want to make sure that they've had, say, their thyroid checked ahead of time, their TSH levels, and vitamins B12, and thiamine and other labs like that. Because if they are deficient in any of those, that could be part of the problem.
And wondering if you could elaborate on the inverted U or J curve when discussing doses.
So we see these inverted, so the J curve, kind of, you've seen a lot of things, and the inverted U curve, right? I think if I'm just going to generalize with it, it's all about moderation. I think we see that in lots of things in life, that abstaining completely from something doesn't necessarily have any benefits, but going hog wild has negative effects. So in terms of sort of stress level, if you think about like high-powered folks or researchers, or, there's kind of this zone of maximal productivity. And if your anxiety levels or stress levels get too high, you start to decline in your ability. But if you were too low stress, and what was the character from Fast Times at Ridgemont High? I'm totally forgetting the surfer dude's name, but like he was a little low on the left side of the curve there. So there is sort of, with most things, this sweet spot. And of course, research can help us identify, sort of by looking at natural conditions, and say that alcohol one with the mortality, to identify sort of, well, where is it? Similarly with the exercise, those were more naturalistic studies where people were just doing different amounts of exercise and then looking at what their mortality was like. One can certainly argue, though, that that's like a population level almost picture. Each person is an individual, and we do have to be a little tuned in, especially when we're working directly with patients, onto that individual and really thinking about them. Oh,
okay.
I do one in the audience.
Oh,
yeah.
So in your clinic, what do you guys do? Like, is it a screening process, or is it like MRI?
So the question in my clinic is kind of like, well, what do I do? Which is a good one. So I'm at the VA for all my clinical work, and it is a memory, I hate the name, but it's a memory disorders clinic, essentially, with MDs, and me as a neuropsychologist. We tend to see folks that are causing head scratching among either the primary care clinicians, maybe someone's psychiatrist, maybe neurology even, just due to complexity of the case. But the sort of basic dementia workup is looking at labs, maybe a brain MRI depending on the timing of things, not always though. Again, it's a clinical syndrome. And so kind of then going forward from there. If folks are already in more of a moderate stage of dementia before they come to attention, they often don't need my type of evaluation, which is like a 4-hour, hour-long interview and 3 hours of cognitive testing. A MoCA score, that's that Montreal Cognitive Assessment score, of 12, and ruling out all other possible causes of dementia other than neurodegenerative disease might be sufficient at that point. Yeah, thanks for the question. I'll take a chat one.
Okay, so wondering about the effects of hormone replacement therapy on the development of dementia?
That's such a good question. I think I chickened out of putting it in the talk because it really is a whole talk unto itself. So there was this awesome trial put together, I'm trying to think when it was happening, like the late 90s, early 2000s, the Women's Health Initiative. And it was specifically looking at, trying to look at, in both observational cohorts, diet modification cohorts, as well as active hormone replacement manipulations, what sort of benefits there could be. And it was actually shut down early. Because they weren't finding positive benefits. And in fact, there were some suggestions that perhaps hormone replacement therapy was bad. I don't think it was necessarily that it was causing dementia. I think it was more the concern was certain types of cancer, and maybe even, I'm going to blank on this one, Barb's going to nod her head or shake her head at me, but I want to say maybe even there was some heart disease, cardiovascular things involved as well. Now, that was a large-scale trial. And many people have looked at it since then and also dissected sort of different aspects of the different still dissecting. Yes, that's a really good point. People are still dissecting the different aspects of that study, and not so much what went wrong, but what can we glean from it? I think one of the biggest take-home messages is there is no one-size-fits-all for treatments. And it really lumped a lot of people together. When you look at folks who take hormone replacement therapy for a shorter period of time, around the postmenopausal period, I think typically for like less than 10 years, those folks, there are some indications, may show actually some benefits later on down the line in terms of dementia incidence and other health conditions. But what definitely does seem to have come out is the taking hormone replacement therapy from the time of menopause or pre-menopause, sort of as perimenopause is happening, through till death is not recommended. So, you know, there's so much, it's funny. I know people, it's really hard to let go of it. I don't want to let go of it personally. But there's so much research in animal models that shows these positive effects in terms of neuronal connections, synaptogenesis, and show that depletion of estrogen or the drop that occurs that would be similar to what occurs in menopause can actually be disastrous. So I still think there's something there. But it may come down to that only in women with certain risk factors is it beneficial. It may be this genetic interaction too of, so there's lots of genome-wide association studies that are being done, and those were being done kind of across the board at first, but we're really realizing that there's different phenotypes of cognitive impairment. There are differences, sex differences, as well as ApoE4 interactions that come into play. But at this point, for clinical purposes, you can neither recommend nor basically that I would not step into the hormone replacement therapy realm in terms of a recommended preventive treatment of any kind. I hope that answers the question as I went off on a, where's that soapbox? I don't know.
No, you know that I've been at
Is
the
that your area of research?
for that study for 25 years.
So Barb is saying that she, that's been her. Oh, they can hear you. Okay, yeah. Well, so, and sorry, just a little anecdote since I've got time, is actually that was supposed to be my dissertation. I had done sort of my master's level thesis looking at hormone replacement therapy. And so we often look at memory both in terms of short-term encoding and then short delay. And that's what we do in our clinic. Well, I created a paradigm where I then was doing that, but then additionally testing a week to 2 weeks later, both those time points, sort of a longer retention type trial in women who were in the diet modification arm of the study, as well as the observational arm of the study. And I was, this is at Northwestern. And so I was putting this all together and then had created sort of a manipulation where I was going to work with more middle-aged women, although they're really not that, but like in their late 30s and early 40s who are doing hormone manipulations as part of fertility treatments or post-cancer. And I was creating a similar design to look at the effects on memory there. And I got embargoed. So I had just defended my dissertation proposal and it came down the pike that everything stopped. Nothing can be published from this. We're at the uppermost levels reviewing the data, and a little student like me was not going to get anywhere with that. So that's all right. I switched gears. I went into functional neuroimaging. So everybody has some little loopholes.
Okay, well, we'll talk
next
more
question,
later.
Next question, yeah.
Has there been any research on periodic fasting as a preventative measure?
Well, that is certainly popular these days. I don't know anything about that. I haven't seen anyone take that to sort of the dementia cognitive impairment level yet. It's more recent, I feel like, that it's really kind of been popping up. I would argue that if it's gonna get looked at, it's gonna need to be looked at in like 30 years from now, when the people that are in their 30s doing it now are sort of coming into potential dementia risk age. I would very much caution against having our older adult patients to kind of take that risk of having significant hypoglycemia or other situations that could happen. I've tried a little of the sort of intermittent fasting kind of thing myself, although I got to admit, I'm like the most half-hearted. I'm fasting except for that milk in my coffee. Oh yeah, I'm totally fasting except for another latte. But I do know that like, I don't feel that cognitively sharp sometimes if I'm not kind of tuning it right. So I would argue that the jury's really still out there. And is anyone throwing in the cannabinoids and marijuana question? Not yet. Oh, okay. Well, then I'm not talking about it. I'm not talking about it for sure.
Here's an interesting one. What about water bottles that generate hydrogen in water? Do they affect brain function? I've heard that.
Oh my gosh. See, every time I get to give a talk like this, I learn something new. I haven't heard of that. If the person who asked that question is still on, would you please email me, and together we will delve into the literature. Yeah, I'm not sure if you mean more like the soda stream types of bottles, like the creation there of the carbonation, or if there's something I'm missing out of the question.
Okay. Is there increased risk for development of dementia with concussion or traumatic brain injury?
I'll never get out of having to talk about this. So I appreciate this question. I definitely, when I was in my training, it was something that had been found that having had a moderate or severe traumatic brain injury does increase one's risk for dementia. I think that mostly holds still true to today. Although there is some research that's more in these larger cohort studies that doesn't find as strong of an association as was found sort of back in the 90s and early 2000s. But what you probably, the poster really wanted to hear about more was actually this idea of sort of repetitive, mild head injuries or blast traumas that have been associated with a condition, a pathological condition called chronic traumatic encephalopathy. This is like the muddiest area in terms of brain research and neuropsychology right now. I can say this: repeated injuries to the brain are not good. And I know that sounds like a no-duh thing, except that that's almost like the people are so polarized on the topic that it's like some folks are like, no, it's no big deal. You know, the brain is designed to handle this, and it really is. Our brains are amazing. We've got this skull, we've got cerebrospinal fluid, there's multiple meningeal layers in there. But we also have some really delicate parts in the brain, and we didn't evolve in a time period where there were IEDs exploding in Afghanistan and folks were being subjected to multiple blasts. We didn't live in a time where people are going into outer space and subjected to how many G's of gravitational force. So there's all these different things that we as humans are doing to ourselves that can potentially impact. I would just say the jury's still out. A lot of the studies of chronic traumatic encephalopathy, the CTE that are out there, are so biased. They're not well controlled. I feel like there's going to be something there, but a lot of what's been published is just not, it's an area of research in its infancy is the nicest thing to say.
Okay, so they say they'll have Kathy email you about the water bottle question.
Oh, please, thank you.
It's from Riverstone Health. So the next one is asking about antivirals for treating dementia, Yeah,
so this kind of, first of all, we need to figure out for sure whether there's some sort of viral cause of dementia. And that was something that's been in the news as well. I swear there was actually a period where there was like this, essentially a fungus among us kind of argued that there was a fungal infection that was linked to Alzheimer's disease. It's just, dementias are so complex. There is literally no one thing that causes them. And so what I think we're going to discover is there's this crazy mixture of like genetic risk factors, health behavior risk factors, and then there's probably something somewhere along the line that kind of either disrupts the blood-brain barrier, whether it's a viral cause, whether it's a surgical cause, whether, it's some sort of exposure, and that maybe that then is something that helps trigger the cascade of pathology that eventually leads to dementia. So certainly can't tell you that I know of any antiviral medications that are being researched right now, we would have to identify a specific virus to target. Yeah.
I know the Alzheimer's Association recommends screening for all adults over 65, I think. Can you comment on that?
Oh, that's quite contrary to what I had thought was the Alzheimer's Association's stance on that. But I could be incorrect. I think, I guess I have to remember, I operate day by day with the federal government VA guidelines, and that is to not do systematic screening. And no, people that can't see me can't see that I'm doing air quotes on screening. What makes a good screen? Something where you test positive and that means you have it. Guess what? We don't have anything like that for dementia. We have these brief memory tests and measures, and some of them have good sensitivity to something, but they're not specific. And so you got to be really careful to recommend. That's kind of why I read those UK guidelines. You got to be really thoughtful if you're going to institute something like that. So I would back the Alzheimer's Association up if that's their current stance, really more from the perspective like, let's normalize this in terms of it's so common. Let's not treat dementia like it's something that should hide in the corner and, oh, we're not going to talk about mom and she's having all these problems until she gets lost somewhere. Like, go ahead. If her doctor's office had it sort of as a more regular thing, just the same way you check blood pressure, I think it would take some of the negative associations away. But that's a big, long way from something being like public policy implemented, like CDC recommended kinds of measures.
So Riverstone Health, I didn't know this either, is saying it's a mandatory component of the Medicare annual wellness visit.
Oh gosh, are you sure for everyone over 65? I thought it was only if there were some red flags that were in place. Now, mind you, it's easy to find a red flag if you want to, right? If someone's coming in because they have diabetes and they're 68, well, one could argue that that's such a significant risk factor that it's a red flag, or I say red flag, a risk factor that would suggest that you should do a screening. And again, air quotes, screening. I use that term myself. I say screening. It's not truly a screening. We don't have a blood test. We don't have anything like that. I'll have to delve into the CMS. Thank you for, is that Riverstone you said was providing this information? Yeah, thank you. I should up my knowledge of other folks' like, little organizations like Medicare, what their policies are. Yeah, I have a question in this audience here.
So I just had a question about how you define midlife, because you have this point about high blood pressure in midlife associated with higher incidence.
So the question I got was, how does one define midlife? Because I was talking about like how hypertension control it's becoming clearer that control in midlife is actually what's truly critical. Midlife is as easy to define as later life. And it's a moving target a little bit, right? And that's also why you have to read your studies critically. I've seen research studies that refer to older adults as people over 50. I've seen older studies that refer to older adults as only people over 75. Midlife, I think, used to kind of be like 35 to 55. I think a lot of researchers more agree on either more of a 40 to 60 or 45 to 65 range. Barb, is that kind of what you're seeing as well? I personally like the shifting, but it's not really, I'm laughing here because I'm clearly in the midlife stage. But I think also it's not just a shifting like for vanity's sake. It's a shifting because we are living longer. So if our lifespan is now till 80, defining midlife as ending at 45 or 50 is crazy.
So we are getting Terry Egan in Missoula also saying it's a component of the Medicare annual wellness visit, and Riverstone mentioned it would just be basic screening such as the mini cog.
Oh, okay.
But I'll give you another question here, if you don't mind.
Oh, okay. Well, quickly though, I'll say one thing about that. So first of all, hi Terry. I've gotten to go to Montana and give a talk with them. They have this awesome group there. But I would say, that's kind of that makes some sense if you think about as care providers, there are many situations in which people have to give consent to do things, and we prescribe, people prescribe complicated regimens, or they have wound care after being discharged from the hospital. So having some sense whether someone is grossly cognitively intact or not is probably a really good idea for those reasons. So I appreciate being updated on my Medicare knowledge there. Thanks. So I'll take that other question too.
Okay, let's see. What about the news recently about gum disease?
Oh, yeah, gum disease. Wow. So that's really interesting, because remember we were talking about the viral sort of potential before. I can't help but think that some of that link might be sort of with and I don't mean just because it's close to our brains, but if you think about it, the connections there and some of the openings that we have of ways to transmit things into our brain are very active for our mouths, our eyes, and some other parts of the body. So you could argue that maybe there's some bacteria or some other things that are basically in a state of risk having an effect. So there's the gingivitis stuff that's been out recently, the gum disease, excuse me. And then also last summer, there was a bunch of research that was being talked about in terms of hearing loss. That is one I do scratch my head about, because I feel like there's so many confounds with this argument that hearing loss is a risk factor for cognitive impairment. I scratch my head with that one because I spend so much time as a neuropsychologist basically trying to rule out someone's hearing loss as being the reason people think they have cognitive impairment. Because lots of people have hearing loss and no cognitive impairment. So we'll see sort of what happens with that one. It could, again, right, if you're having I'm blanking on the most common cause of hearing loss, sensorineural hearing loss. Is there something happening there that also maybe is having some interaction in terms of brain function, or kind of a neural change there that then sort of has a Wallerian effect into the brain? I don't know. That was a tangent.
Okay, regarding the connection to PTSD in veterans, has there been other research or connections to other sources of trauma, including age and duration experienced?
Yeah, so I don't know of any terrific research in other populations. And I have a whole talk about PTSD and dementia and aging because it is more complicated than what I even presented. While across the board, there does seem to be this doubled risk, it is really interesting that if you look at folks who got Purple Hearts versus those that didn't, those folks are less likely to have PTSD. When we think about survivors of other trauma, those that were sort of celebrated and well cared for afterward tend to not show some of these associations. I'm trying to think. In folks with PTSD, it doesn't seem to matter whether it's combat related or non-combat related PTSD. So there's not this direct, and this is where PTSD is so complicated, really. There's just not a one-to-one relationship between trauma and developing PTSD. So then you kind of get sucked into what are the factors that maybe seems to make someone more likely to develop PTSD from traumatic events. And there's a whole big old, mess of things there that also some of those are risk factors for developing dementia. And I say risk factor, things that are linked with higher rates of dementia, so low education, low SES, and things like that. So the person in the audience just said, well, that's a rabbit hole. And I'm like, yes.
Well, so someone is asking, could you say that again about the Purple Heart? If they were celebrated, there was less?
Oh, sorry. I mean, we think about a lot of this research looking at PTSD. So PTSD wasn't even a diagnosis with that acronym, with that specific criteria until 1980. And it really was developed to describe the after effects of some folks to trauma in our Vietnam veterans, really here in the United States. So if you think about it, those Vietnam vets, there's just kind of this understanding. They came back and they got spit on, they were baby killers. They actually did get told to do and did often horrible things. And you contrast to that to previous conflicts where they were heroes when they came back and there were ticker tape parades. But then you can't even untangle that from the fact that so many of these Vietnam vets, and they started doing drugs over in Asia. They started drinking, they developed drinking problems. So Agent Orange exposure, could it, you know, it's incredibly complex. But so the reason I said the Purple Heart thing was that was a really concrete thing that one of the studies, it was Qureshi and colleagues, I think it was published in 2012, specifically compared the Purple Heart recipients with PTSD versus those without Purple Hearts with PTSD, and those with the Purple Hearts showed less of a risk of developing dementia. I mean, again, these are all associations and extrapolations, and you know, we have to be very careful with these types of research studies to not infer causal associations.
Okay, do dementia rates vary amongst countries?
Oh, there's always someone who's going to really tap into one of my areas of weakness. And that is, one of my areas of weakness is that I am so in deep with the sort of the United States population and numbers here that I really am not up on dementia incidence. There's sort of this finding recently that there seems to be a global dropping of the rate of new cases. I know there are certain populations that have lower rates. It gets really tricky though, because if you say that there's lower rates in a country, and I always hate this first world, third world stuff, but in a country where you're dealing with malaria as a cause of death, or a much younger lifespan, I don't know if you're really comparing apples and apples. I know, interestingly, that say in Japan, vascular dementia is their #1 age-related dementia. Alzheimer's disease is not first there, but the exact reason for that is also not understood.
What about our ongoing global exposure to nuclear radiation and geoengineering elements such as nanoparticles of aluminum?
I'm sorry, I can't answer your question right now because I've just curled up in a ball in the corner. I don't know. I really don't know. I mean, there's so many environmental ills going on that we'll be lucky if we get to deal with that in 3 to 10 generations time, because I feel like there's some other nasty things that could happen sooner. Sorry, definitely not my area of expertise there. I literally, you have to realize as people asking these heavier questions, I have to go into work every day and I work with people, and in the face of chronic, debilitating, leading to death illness, I am an optimist and I help instill hope. So I'm really glad there's other people thinking about this, but if I think about it too much, I probably would not. I would not be functional, a good clinician at least.
Well, and on that note, we have no more questions.
Okay, everyone's like, oh my
gosh,
gosh,
Dr. Trittschuh.